the topic that I'll be discussing today, diabetes mellitus, with an emphasis on surgical complications. So in general, we all know that diabetes is a metabolic disorder that's characterized by hyperglycemia that develops either due to insulin deficiency, which can be complete, or it can be relative, or it can be due to both abnormalities. And it's classified into type 1 and 2 based on the type of insulin abnormality that's there. And the complications of this can either be acute or chronic. And there are a lot of complications of diabetes. As you can see on this slide, the complications are multisystemic. However, we will focus more on the long-term complications. The acute complications are those related to the glucose level, which is the hypo and hyperglycemia, and the long-term complications are those that are more complex. This includes vascular complications, abnormalities in the immune system, and these vascular complications are also divided into two types, which can be microvascular and macrovascular. And these macrovascular ones usually affect small and medium-sized blood vessels. And then the microvascular ones affect the smaller blood vessels, or rather the capillaries, and the effects of which are those that are listed there, which I will continue to discuss further. So I put this slide here. You know, many of us use the terms diabetic foot and diabetic foot sepsis interchangeably, but are these things the same? So to many people, it's the same thing, diabetic foot sepsis. But however, you must be aware that the diabetic foot is simply the foot of a diabetic patient that has signs of long-term complications, such as either vascular complications or neuropathy. Whereas the diabetic foot sepsis is when there is an complication with infection now. So this is an infection that involves the foot of a diabetic person, and this infection usually originates from a chronic ulcer or an acute injury, and this patient must have evidence of existing neuropathy or ischemia. So now, these complications of diabetes, how does this occur? How does the patient develop this? And unfortunately, the pathogenesis to this is multifactorial and again complex. So there's the vasculopathy, the neuropathy, there's the immunopathy, and all of these are related to prolonged hyperglycemia, and this contributes to this in different mechanisms. So now let's look at the vasculopathy. So we have microvascular abnormalities. So this is involvement of the small blood vessels, meaning the capillaries, and how this results to neuropathy. Again, like I said, it's complex. There's multiple mechanisms, but of note is that histologically, when you look at the capillaries of a diabetic patient, you will note that there's thickness of the basement membrane. And this is what happens to the small blood vessels that supply blood to the nerves, the small blood vessels within the functional unit of the kidney, the glomerulus, as well as in the retina, and all of this stuff results in the other complications. And then the macrovascular complications, this is affectation of the medium-sized blood vessels as well as the small vessels. And here, histologically, you cannot differentiate whether this is due to diabetes or other causes of or dyslipidemia, because this is when patients now present with ischemic limb disease, which is due to atherosclerosis. But the atherosclerotic plaques that occur in diabetics usually specifically occurs in the small or medium-sized blood vessels, meaning that if this patient is to present with limb ischemia, the pathology will be usually in the vessels below the knee, and they are unlikely to present with an aneurysm or anything like that. And then now when we go back into more detail to this diabetic neuropathy, what is it? So this affects all types of nerves, sensory, motor, as well as the autonomic nervous system. And like I said, there's many different mechanisms. One of the mechanisms is that the hyperglycemia itself causes an osmotic gradient that draws water into the nerve sheath, and that results in edema and demyelination of the nerve sheath. Another another that I've already mentioned is the microvascular problem. The capillaries with the thickened basement membrane, decreased permeability, as well as occlusion. The blood supply to the nerves is also affected by this. And again, there's also theories related to the sorbitol pathway, where they, due to inhibition of the sorbitol dehydrogenase enzyme, you find that there's accumulation of sorbitol within the nerve sheath, and then this also results in an osmotic gradient that draws water into the nerve sheath, demyelination, and again dysfunctioning of the nerves. And once this happens with the sensory nerves, the patient will lose sensation, they will have trauma on the feet, which they won't notice, they will be wearing tight shoes and they cannot feel that the shoes are tight. And progression of this, if it's unchecked, results in pressure necrosis and ulcer formation. And the loss of motor function as well results in weakness and wasting of some of the intrinsic muscles of the foot. And when this happens, the patients will develop different deformities on the feet depending on the muscle groups that are affected. And this will result in development of pressure areas. Patient will have an abnormal gait, and again contributing to ulceration. And the abnormality in the autonomic nervous system. These patients now, they cannot feel that their skin is dry because of the autonomic nervous system. They will have decreased sweating, they'll have dry and brittle skin, which is predisposed to cracking and fissures, and then with secondary infection, this results in ulceration. So in this slide, this picture just shows some of the abnormalities that you would see when you look at the foot of a diabetic patient. So on this first picture, I'm not sure if you can see my pointer, if you can see my cursor, you can see on the first picture, this is a patient who has developed what is called hallux valgus, meaning that's the medial deviation of the big toe. You can see that also on the x-ray. This is a patient now who has wasting of the intrinsic muscles of the foot, and then that results in a claw foot. And then this will result in pressure areas around these areas, as well as on the dorsum of the toes. And if this continues unchecked, the patient will, you will see, like when the patient takes off their shoes, you can see that there is pressure around the bony prominences of the foot. And when this continues, you will have callus formation, and then progresses to ulceration. And when it's unchecked, it will progress to gangrene. It's noisy. It will progress to gangrene. And then, so on this slide, again, there's the abnormalities of the immune system. So the patients already have loss of motor function, sensation, autonomic system is abnormal, the blood flow is abnormal, and now they also have abnormalities of the immune system. So this, again, it's complex, and both the humoral and cellular immune system gets involved. These patients have decreased migration of polymorphic nuclear cells, they have decreased phagocytosis, they have decreased intracellular. Even if phagocytosis occurs, there's decreased intracellular killing of the organism, there's decreased chemotaxis, and all of this impairs their defenses against infection. So now, looking at all of this, now you are aware that now for a patient to develop a diabetic foot ulcer, there's many factors that play a role. The neuropathy, the vasculopathy, and now once this occurs, the patient also has immunopathy. They cannot defend themselves against the infection. So now, how do we assess these patients? So the most important thing is, after doing your general examination, the most important thing is to look at the patient's foot. Inspect the foot, look for deformities, look for ulceration, look at the skin, and then now assess the patient's sensation. You can check, assess for soft touch, use a cotton bud to just touch the skin to see if the patient can feel it. Assess them for pressure, can they feel different temperature? You can assess for vibration as well if you have a tuning fork. I think you use a tuning fork that's around 128 hertz. Assess the motor function. assess as well the peripheral pulses. Something I forgot to include here is that, which is demonstrated in this picture, you also need to assess the patient for proprioception. What is that? This is assessing the patient's ability to sense where their body part is, meaning that you ask the patient to close their eyes and then move their toes, ask them, where is your big toe pointing now? They're pointing up or down. And you'll be surprised that these patients also lose proprioception, which is part of the autonomic nervous system. They lose proprioception. This is why they have an abnormal gait, and they tend to get injured. This makes them prone to injury because of the abnormal gait. Now, once you've assessed the patient and made the diagnosis that your patient has a diabetic foot, meaning that your patient has signs that show long-term complication of diabetes, what do you do with this patient? So this requires a multidisciplinary team for you to manage this patient. And of note is that nothing beats prevention. How do you prevent this? Patient education. If the patients are educated, if you routinely inspect your patient's feet, then you'll be able to prevent this. But however, in the patients who are already missed, early diagnosis and early referral to the correct specialist or treatment center is also helpful, and it will save the patient's limbs. And there the patient can be offered corrective treatment. It can be different corrective treatments. And what are the options that we have for these patients? So like I said, this needs a team of healthcare professionals for you to be able to assess the patient. Of note, ideally, you would want to start from the primary health care. This is where we hope primary health care needs to control the patient's glucose and keep the patient as close to normal glycemia as possible. And should that fail, the patient needs to be referred to the physicians again to control the glucose, because controlling the glucose also slows down the progression of the disease that has already started, or it will prevent the complications in the patients who are newly diagnosed. So glucose control is very important. So the relationship with primary health care and physicians is very important. Not forgetting the dietitians as well, because the dietitians as well, their input will assist the patient in glycemic control. And again, ideally, we should be having podiatrists in primary health care, because their service is very important, because there's these small things like dealing with calluses on the food, nail care on the diabetic patients. So this is something that doctors don't like to deal with, but podiatrists enjoy, or this is one of the things that they do best, taking care of patients' feet. So they will assist with taking care of calluses and abnormal growing nails and all of that. But however, for the patients who already have developed complications, physiotherapy, as they will assist with keeping the patient active, as well as assisting in the patients who already have some deformities with correcting their gait and all, and something like that. And then also orthopedic surgery, they can also offer corrective surgery for the patients who already have hallucis valgus, who already have a Charcot's foot. They can offer corrective surgery for that. However, when there's like loads and loads of patients, then the waiting list will be long by the time the patient makes it to the orthopedic surgeon, or then it's already too late. The deformity cannot be corrected. Ideally, the patient shouldn't make it to the general and vascular surgeon, because once the patient makes it there, it means the team has already failed the patient, because now it means the patient either needs revascularization, which is very difficult in the vessels below the knee, or the patient needs an amputation, which means that the patient has already lost the foot. So ideally, the patient shouldn't get to needing a general surgeons. Now, should all of these things or all of the team fail to prevent the diabetic foot will complicate into diabetic foot sepsis. So like I've said before, the development of a diabetic foot sepsis, this results from the diabetic foot triad progressing unchecked. And usually these patients don't only present to the diabetic foot, their presentation is usually complicated by other acute problems such as DKA, HHS, And besides the diabetic foot sepsis, they also have other long-term complications of diabetes. This patient may have ischemic heart disease, they may have nephropathy, they may already have history of stroke and all of that, so which makes the management of the patient complicated. However, when the patient presents with a diabetic foot sepsis, what's important is that we're going to grade the foot sepsis. There's different grading systems. There's Wagner classification, University of Texas, Wi-Fi. The Wagner classification, I like this one because it's easier to remember, and it's widely used and it's easy to remember compared to the others because the components are not many. However, this classification only classifies the sepsis on the foot. You would see a grade 0 is a patient with a diabetic foot but with no sepsis, and it will go from grade 1 to superficial to a superficially infected wound, to a deeper wound, and then to grade 3 where you have now a deep ulcer with plus minus an abscess or even osteomyelitis. And grade 4 and 5 is now severe infection with associated gangrene, either minor gangrene or extensive gangrene. Whereas these other classification, University of Texas also classifies ischemia in the patient, meaning you will classify the level of infection as well as whether there's associated ischemia or not. And then the Wi-Fi classification also assesses the wound, the infection, as well as ischemia. The only difference between these two is that this uses objective tests to assess for ischemia in the limb, and it's more comprehensive compared to the other one as it's the more recent classification. But however, you can use any one that you're comfortable with. For me, the easier the better. I would rather use the Wagner classification because it's easier to remember. Now, when this patient presents with this diabetic foot sepsis, what are the principles of management? Like I said, because the patient also has acute complications occurring at the same time, it's important that we correct the fluid and electrolyte status of the patient. Glycemic control will be the next important thing. You would use whatever is available to you. You can use a sliding scale. If your patient has close monitoring, ICU, high care, you can use insulin infusion. However, like I say, you need to be able to monitor the patient if you're going to use insulin infusion. And again, early initiation of antibiotics. According to the surviving sepsis guideline, early initiation of antibiotics means within the first 30 minutes after making the diagnosis, the patient must be on broad spectrum antibiotics. And lastly, it will be source control, which most of the time involves some kind of surgery. Now, the diabetic patient or the patient with a diabetic foot sepsis is not the type of patient who arrives in casualty and then you would scoop the patient and run to theater. No, this patient needs to be prepared for theater because otherwise mortality and morbidity is high if the patient goes to theater unprepared. So what do we mean? It means that the endpoints of your resuscitation must be met. Glycemic control, you are aiming to at least a glucose of less than 15. It doesn't have to be back to normal. If the patient comes with unrecordable glucose, if it gets to 15, it's acceptable that the patient can survive anesthesia. Your electrolytes, the potassium, the sodium, get them as close to normal as possible. The patient must have adequate urine output to make sure that the patient is adequately volume resuscitated. And there you want the urine output of at least a ml per hour, a ml per kilo per hour. So that you know that your patient is adequately volume resuscitated, especially because most of the time patients who need amputation or foot surgery are given spinal surgery. So if they are not adequately fluid resuscitated, the patient will crash because they will vasodilate and crash. And again, don't forget, most of us forget that the diabetic patient has diabetic neuropathy, which affects the autonomic nervous system, including that of the GIT. So a nasogastric tube is important because these patients have gastroparesis and delayed gastric emptying, which makes them prone to aspiration when they are given anesthesia. So an NG tube to decompress the stomach is important. And of course, basic investigations that you need to have before you take your patient to theater: an arterial blood gas, it will tell you how your fluid status is, about your electrolytes, and the patient's oxygenation status. Basic blood investigations, at least the patient must have a chest x-ray, and you must also have an x-ray of the affected limb for you to be able to assess the extent of the disease. Because like I said, what you see on the wound might not necessarily reflect what's happening inside. So you need to know if there is bony involvement so that you can make the correct surgery decision can be made. And again, because of the autonomic neuropathy, the patients can have silent myocardial infarction. So at least you need an ECG to check if there's no silent ischemia. So now types of surgery depends on the extent of the infection. So this is now a guideline to say patient with Wagner 1 or 3. So this is a patient who has either a superficial wound or the patient has an abscess within the forefoot. So this patient can be offered a debridement or even an incision and drainage if it's an abscess. However, if the patient has Wagner 1 to 3, but also has osteomyelitis on X-ray, meaning there's bony involvement, this patient will most likely benefit from amputation. And then Wagner 4, this is a patient who have localized gangrene. So depending on the areas that are involved, the patient may benefit from a toectomy or a ray amputation or even a forefoot amputation, transmetatarsal. Wagner 5, so this is the patient now who has severe diabetic foot sepsis, who needs a major amputation either below or above knee, and preferably this should be a staged amputation, meaning that you would do a guillotine amputation just to ablate the sepsis, continue antibiotics and resuscitation, and when the patient is now well resuscitating and the level of infection is well demarcated, then the amputation can be formalized. But now, why did we decide to talk about this topic? Like Dr. Mawela said in the beginning, 50 to 75% of lower extremity amputations are performed on diabetic patients, and more than 50% of these amputations are thought to be preventable, provided that the patients were educated about foot care and we'd examine them and did corrective treatment to try and prevent them from developing amputation. And again, this is a very costly disease to treat. Diabetic in itself is a costly, it's very costly to the Department of Health to treat. This patient needs to be, the department needs to buy glucometers for the patients. There's the medication, there's the insulin sticks. This is a lot of money. When they develop renal failure, there's renal dialysis. Now, when we add amputation on top, which is even more costly, because now after the patient has been amputated, there is rehabilitation that needs to happen. There is assistant mobilization devices like wheelchair, crutches, special shoes. All of those things are extremely costly. There's wound care, there's permanent disability and loss of income, meaning increasing dependency on the state. So this is a very costly disease, which is important that we must try and prevent it. This is just a slide I got from some research that was done in Europe. So you see that of all the diabetic complications, there is angina, there is strokes, there's eye disease. All of these things are costly, and this is how much of the budget they take from the health system. And this one written in blue or purple, this is the foot complications, either the ischemic foot disease or the foot sepsis. So this is how much it costs to treat these patients. And again, there's loss of limbs, there's loss of money, but ultimately there's loss of life. So this is a very dangerous disease, which can ultimately lead to loss of the life of a patient, which can occur either acutely or it can occur as a complication after the patient has been amputated. We've noticed that you are most likely to die after you've been amputated, after you've had an above knee amputation. Your health status debilitates you because of your physical status, your failure to take care of yourself. The patient is most likely to die compared to someone who's diagnosed with cancer. Now, that's unacceptable. So this is why we need to prevent patients from developing diabetic foot and diabetic foot sepsis. That being said, I'm aware that in our health system, we still have a lot of challenges, which includes delayed presentation. There's cultural beliefs that factor in, which leads our patients to come late or to refuse treatment or to seek alternative care. And then which further delays their treatment, because if they believe that this is caused by something else, then they would not agree to the medical treatment. And as well as we are aware that the training of the people who see so basically like we as surgeons only see the complications, but you don't have access to the patient before they develop the diabetic foot or before they develop the diabetic foot sepsis. So the substandard training of the staff in the primary health care or the first line people in the district hospital. So we need to try and do something about this if we are going to prevent this. And again, the staffing, there is no allied health professionals in primary health care, no podiatrists to give these patients primary health care to assist in preventing this. And on top of that, some of the patients who eventually get diagnosed and need surgical care, it's unbelievable that in this country, there's still people who don't have access to a surgeon. There's still patients who have to travel over 100 kilometers just to access surgical treatment. And most of the patients, because of that, they are discouraged. So the more we talk about this, the more we try to share the knowledge, we hope to change all of this and to offer this patient good quality of care when it comes to management of diabetes and its complications. So now if you forget anything from this, please remember, look at your own feet, look at your patient's feet and educate them to look at your feet, at their feet. Protect the feet of the patients who already have diabetic foot patients. And if we all do this, we will save a lot of feet. Thank you.
Thank you very much, Dr. Bachet. That was quite informative. Yeah, you know, except that you have raised a lot of questions and challenges, and really, you know, these are some of the things we need to deal with. I saw in the attendees there, I have a colleague. I'm gonna just put him on spot. I don't know if he's still here. Dr. Sigo, he's a family physician. You know, I'm hoping he's in a space where he can engage with us, because my own also understanding of a family physician, they are quite involved in the management of chronic diseases, especially diabetes, and mainly because in everything you have discussed, you have overemphasized the importance of an interdisciplinary, multidisciplinary approach. You have mentioned issues around the importance of controlling the sugar, issues with the district health system, you know, particularly the primary health care component of that. I used to do, you know, community campaigns at home. Last Friday at 3 o'clock on the highway, and it was traffic. I used to do community campaigns at home, and I would have these grannies, you know, who come there. The first one I did, I got this granny, her sugar was like 20 something. I said, yeah, we need to do something, you know, and probably send you for review. She said, no, but I was in the clinic, it was like this. Last month it was like this is how it's been, you know. So sometimes I think patients do present, but I think the level of care and the quality of care and our response to these kinds of high sugars and high BPs is actually quite poor. So a few things. There's a statement which I want you to comment on. It's a doctor, and his title is Double Amputation is Common. And this is a comment, it's a quote, right? It says, you chop the leg and send them home, and within a year they are back and you have to chop another one. He says, in that particular year, in South Africa, it was estimated that we had 8,000 new cases of blindness and 2,000 new cases of amputations for that particular year. I don't know, would you like to comment on this? And I mean, you have raised some of the issues, but do you concur with this? You chopped this year, they come back. It seems like even after chopping, we are not winning in terms of improving the sugar control, food care, and other predisposing factors. Thanks, Doc.
Yes, thank you for that comment. So the person who have raised that is absolutely correct, because what we've noticed is that when the patient comes from the first amputation, it's a patient who is referred from 100 kilometers away. They come to the hospital, the patient is offered an amputation, but after amputation, the patient needs to continue attending the amputation clinic for rehabilitation. They need to continue to control the glucose to prevent. They need to do the food care, to take care of the precious limb. However, because now the patient gets discharged and they no longer have access to their dietitian, they no longer have access to the physiotherapist and the wound care nurses, the patient goes back to re-enter the same cycle again of having persistent hyperglycemia. And the only time that the family feels that the patient must come back is when the patient now has severe disease, it's now a smelly food, it's necrotic, and now people feel like, yeah, now we have no choice, we have to travel the 100 kilometers again to take the patient back for another amputation. But they couldn't afford, many patients can't afford to do ups and downs to come see a physiotherapist. So it's true that most of the patients, once you are amputated, within the 2 or 3 years, you will have a second amputation. And within 5, 6 years, these patients have died. So it is true.
Yeah, and I see Yoli made it's a question actually. I don't know, it's a comment that I don't know whether you are the right person. And maybe Dr. Siko, I would like to hear your comments after this one. She says, what do you do if, and I think it's probably a primary healthcare, practitioner who has referred a client with a diabetic foot, which could be early sometimes, but unfortunately, it seems like patients do come back, and this might be linked to your earlier challenge around the lack of surgical skills as well. I'm not sure if you have an advice for Yoli, so I think it's a systems problem. You are not the ABC, but what's your immediate feedback to her? Yeah.
There's many reasons why patients who are referred, then they get sent back to the person who referred them, and nothing is done. Like I said, for example, the patient will come and have a foot deformity. They need an orthopedic surgeon to fix the bones so that they release the pressure, or they need one of the workshops, they're working with the OT to create a shoe for them to relieve pressure from the forefoot or something like that. But however, because the system is also flooded with many patients, the patient is told is going to be on the waiting list for an orthopedic operation for 6 months. And the patient is going to wait for a safe shoe or an offloading shoe for 8 months while it's being ordered from somewhere in Cape Town or wherever. And patients lose patience. And also sometimes it happens that the patient is referred to the correct institution, and the person who sees the person in the, who consults or sees the patient in that referral institution also makes the wrong decision. It's also possible because it's not everyone who is in the academic institution who knows. There's interns, there's conservators, there's sessional doctors, there's everyone, all the levels of healthcare professionals are there. And it's possible that a wrong decision was made. So I think if something like that happens, it's better to be persistent and rediscuss the patient and refer the patient again. And also, this is why we are having this discussion, so that this shouldn't happen.
Yeah, so I think ultimately, Yoli, you have to be a patient advocate, which is one of the important skills required of a health professional. So for any patient where you believe that the patient did not receive the right level of care or the right quality of care, as a health professional, that is where you have to communicate, you have to advocate, call the same institution, or even within your institution, talk to higher managers there, because if we do not advocate on behalf of our clients, it becomes a bit complex. Before I take Dr. Morato's hand, Dr. Sigo, are you able to hear me?
Yes, I can hear you, Brales.
Yes, thank you very much. I know this is your field, probably as a family physician. Dr. Machete seems like she's presenting towards the end, you know, when now things have already gone wrong. I don't know if you would like to make some comments around the quality of diabetes services in the country, and how, I don't know what your recommendations or inputs are around improving the control of diabetes at the primary healthcare level. I don't know. Yeah, you may say whatever is in your heart. Thanks.
Yeah, thanks very much. I think it's a sad state of affair that we still having people that we amputate. And like you say, from primary health care point of view, these are the people that have been with us for many years. And the question is, what have we done to make sure that they do not reach that particular stage where they have to be amputated? I remember recently talking with my team of interns and ComServe to say, I think it's about time that we should maybe establish, diabetic clinics or days, special day within our clinic, where really the management of this particular patients become intensified, and that multidisciplinary approach should actually start in our local clinic, where we allocate a special day to say Wednesday is a diabetic day, where our dietitian and any other person that it's important in terms of managing these patients around, and they they bring in their expertise, so that we should not reach a stage where they end up with amputation. So it's an indictment on primary health care, that patients end up being amputated, being blind, from all these complications of diabetes. And we really need to improve our performance in terms of managing this particular patient. I think that will be my comment. But we really appreciate the feedback that we get from tertiary to say, guys, can you really improve, your service at primary health care, so that this particular cases we should not see in our in our institutions. Thanks.
Thank you very much, Dr. Sigo. Dr. Mota, I'm going to come back to you, but for now, I want to take Dr. Moratwa. Your hand is up. You may unmute.
Thank you. Thank you, Dr. Machete, for the great presentation. I just wanted to ask a more surgical question, if it's possible. So in terms of the actual surgical procedure, you use the Wagner classification in particular, but my question is related to then making a decision. Is there a rationale or a system or a suggestion you have for choosing between, let's say, your Lisfranc or Chopart amputations versus your Ray amputations? How do you make the decision? Because what I found is, as a medical officer in public, when we were doing those operations, you sort of made the decision on table, and I didn't find that there was a clear rationale that we all followed. It all seemed to be quite subjective, based on whatever subjective findings the person had on table. If you could just perhaps give me a system to work with that I could start using. Thanks.
Thank you for that, Dr. Morado.
Okay.
I appreciate it.
All right. So the Wagner classification is actually a guide to say the patient presents with this, they are most likely to benefit, or you can offer them this level of amputation. But I think I did mention a statement there that what you see when you examine the patient may just be the tip of the iceberg. There may be a deeper infection that you cannot see. Like, for example, if you have to decide from doing a Ray amputation and a transmetatarsal amputation, or even a below amputation, you will see that I am not going to mention Charcot's amputation or Lensfrick level of amputation, because those two are commonly not done, because rehabilitating those patients or even finding a prosthesis to fit the leg, the foot after you have done a lens freak or a Charcot's amputation is difficult. And most of the time, the patients cannot ambulate anyway after you have done that kind of amputation. So we're sort of trying to do away with them. You are either going to do a minor amputation, which is going to be a toectomy, or if it's more extensive, a toe, take the toe with it, the metatarsal bone, which will be a ray amputation. And then if it's multiple toes affected, then the forefoot will be amputated transmetatarsal, meaning through the metatarsal bones. And if you cannot do that, then the patient needs an above knee amputation or above ankle amputation. So the decision is that when you're looking at the patient, you would say that this patient looks like they need a transmetatarsal amputation. But you keep it in mind that when you do the x-ray, maybe you saw a little bit of gas, look like it's trekking up. And when you consent your patient, you make them aware to say that ideally, I want to do a transmetatarsal amputation, but I'm worried that intra-op, I might find that the infection goes even higher. Do you permit that we can do a higher amputation should it be necessary? So when you do your consent, you must always consent for a bigger procedure than what you intend to do, because you may go and start the operation and find that the infection is more extensive than you thought. So that does happen. The Wagner guides you to say, so that you can plan and prepare the operation, but it does happen to everyone, including us, that you go intra-op and then you find that the infection is more extensive, and there you have no choice but to move on to a major amputation.
Okay.
Yeah, but Doc, tell me then, is the amputation the ultimate, or in today's world are the alternate? I don't know, everything seems to be improving in that space. Do we have any innovations or we are stuck with amputations?
Well, the challenge you have with the diabetic patient is that they have immunopathy. They have an immune system that's already depressed from the prolonged hyperglycemia, meaning that their immune system will not respond just like any other patient who has an abscess on the foot. You keep that in mind. They have abnormal blood vessels. So the blood supply to the infected area is also decreased. So on top of an immune system that's not effective, the delivery of the cells to the infected area is also not effective because of the vascular pathology. So on top of that, then that means also even antibiotic delivery will also not be effective. You will not get the antibiotics to reach the infected site. So as much as people talk about hyperbaric oxygen therapy and all of that stuff, the point is that the longer you wait, the infection progresses. So you always try, if the infection is minor, of course you will do a debridement, you can do an incision and drainage, but you watch the patient closely to say, should I have to amputate? I would save the life first and the limb we lose. So this is how we think about it: life first, and then the limb has to go if we have to save a life, because of all the other factors that play a role in this disease.
Yeah, Dr. Siko, if you are still there, I need you to come back, and then maybe also Dr. Moratwa and yourself, because I would like, because Akona is making a, I don't know if it's a question, it's a comment, and it sounds like she's on the pharmacy side, and she's talking about patients who are seen with high or low sugars, where at the pharmacy level, probably they would engage a clinician, and you find that the instruction is that continue. It's quite a common finding, this, and but the issue I want to raise is about how do we get to this because multidisciplinary in the books, in the presentations, it's something that we write a lot about, but in practice, there is a hierarchical, system. I mean, most of the time, unfortunately, it's doctors at the top of it and everyone else, but we don't seem to appreciate what the different fields in medicine and bring, to the care of the patient, and therefore we are unable to work together. How Siko talks about diabetes days, but the diabetes days without the physio, the OT, without the buy-in of the nurse, the dietitian, and if we can't build a team, which can work together, at the end of the day, the patient suffers. And it seems like at the heart of these issues, it's our inability to work together, as well. I don't know who wants. Maybe let me talk to Dr. Mota. Are you able to unmute before I ask the other colleagues to comment? Dr. Mota?
Hello. Hello.
Yes, Doctor. How are you doing?
I'm okay, just tired.
Yeah, it's been a long day. You have heard my comments and questions. I don't know if you want to comment on this topic, but also on the issue of how we then work together in the interest of saving limbs. Yeah.
No, I think the multidisciplinary thing is not an option. If you consider it an option, you just get frustrated, because from the first patient that you try to assist on your own, because there's so much to do already, you'll compromise what you need to do because you're alone. Yes, and even if you have one patient, so it's not an option it's a must. You haven't started. If you don't have a multidisciplinary team, you haven't started helping the patient. Yeah.
Thank you for that, Doc. Dr. Moratwa, what's your take? And then as doctor, since we are at the top of the pyramid, we are probably the first people who can make the change.
I agree with Dr. Mota. I just think, in my experience, I mean, I'm just a medical officer, but I found that building relationships and people skills in terms of your fellow colleagues, especially ones who are non-doctors, and trying to take an active effort in learning from their way of thinking about patients, their way of managing patients, has been really crucial to me being able to then get what I need for a particular patient. They have long lines and often can't get to an urgent patient as quickly as you want. But the more you build those relationships, you're more likely to get someone to then assist you. So it's almost like so make sure that you go the extra mile, build those relationships amongst your fellow colleagues, especially non-doctors. Really go out of your way to do that. And I find that you can then make it work within the system, despite the challenges that are there. That's how you get around it. In public, that's been my experience.
Sure.
Yeah.
No, thank you for that. That was quite value adding. Dr. Machete, would you like to share how do we do it, or how do you do it at ROPS there? How does it work?
Well, I can't say we are doing it, because all we are doing is seeing the end result of the patient who's already coming and needs to be amputated. But that being said, I'd like to say that I have worked in a district hospital before. And at that time, I was a community service doctor, and I was in a district hospital, and I was left alone, to figure out what to do with the patient. And I am aware that you would work very hard, and the people who are there in the district hospital, they work very hard. They are doing their best to assist the patient, but if you don't have support from the hospital you are referring to, or like, for example, I don't think you can go to Rob Ferreira even now. I don't think there's a tuning fork there in the diabetic clinic, or even in surgical OPD, to assess vibration on the patient's foot. It's not there. You don't even have a handheld Doppler machine to assess the vascular status of the patient. So it's difficult for everyone, but I think it's we should not give up and just say that it's difficult, we can't do it, we don't have this, we don't have that, we don't know that. I feel like if we continue trying to educate each other and plan some kind of outreach, continue with outreach, go to the district hospitals, see what the people who are referring to you, their working environment, their workload, see what they have to go through and see how you can assist them, educate them and how you can assist and all of them so that you can offload them. Then they will have more time for the diabetic patients, you know, unlike sitting here in the referral institution and saying that, yeah, you know, the people from wherever, they are not doing this, but you don't know if it actually even is possible for them to do that, you know. So I think we should be trying to do some outreach, see what the other institutions look like, see the people's working environment, and see what you can chip in, what you can do to assist the other colleagues. That's my take on this.
No, thank you. Thank you very much, Dr. Machete. But before you go, let's talk about increasing access to surgical care, because you have mentioned that as a great challenge. I know that we, as a platform, we are also trying to close that gap, hence the seminars in surgery. Do you have other models or advices you want to share with the colleagues, how they can enhance their surgical skills so that we have more and more people who are able to take care of surgical emergencies?
Well, I feel like it's only us who can help us. Né? So I feel like we as children of the province, we must do something about it, because our children are traveling 400 kilometers to Pretoria to see a pediatric surgeon. Where are all the pediatric surgeons who are born in this province? Why do they then finish and then they go and live in Pretoria and they forget that they left people where they come from? I feel like it's the interns who are from this province must go and learn how to achieve skills and come back and help their people. Other things is that you can enroll in surgical skills courses that will teach you basic surgical skills, so that if you are unable to refer a patient, at least you can do a guillotine amputation. And then the formal amputation can go and be done somewhere else, you know, if you're unable to do the amputation. At least if you ablate the sepsis, then formalization can be done somewhere else. And for you to do a guillotine amputation, I promise you, you don't need a lot of skills. You just need a little bit of bravery. And then with basic surgical skills, you can do a guillotine amputation and you can save a life just by doing that. So, and also there's opportunity to say people who are interested, you can talk to your superiors, ask them to give you a couple of weeks to come and spend in the referral institution and just learn a few things, learn how to do incision and drainage, learn how to do a debridement, learn how to do a guillotine, and then you go back. And then you know that your patients are now safe because you have learned those skills. Because that's something that's doable within doctors who work within the state. So you can come and visit and learn a few skills and then go back and practice them. So I think, yeah, that's what you can do.
I like that last model as well. And I think it's something we have to explore. I've seen it work, you know, for other programs. We need to find ways to make it work. So just as a last question from Anonymous, he says, is there a role for the use of liquid phenytoin to treat infected diabetic foot ulcers? Other countries include this in dressing wounds. I'm not very informed about this. Let me leave it to you if there's anything. Yeah.
Yeah, I didn't know that there's people who are already using it. I think there's some research. I thought it was just something that's being researched. I'm not aware if there's already results from those research and stuff like that, and if it is really effective. So we are not using it at all. I'm not aware if anybody is already using it outside research purposes.
And then let me get Anna, because she's asking about referral. I'm hoping she can talk, because She's saying who to refer to, you know, is it the podiatrist, is it the physician, or is it an orthopedic, guy who must see, you know, the patient. Anna, are you able to unmute? Because I would like you to clarify the type of case you are referring to so that we can, I understand it's multidisciplinary, but it has to start somewhere. Yeah.
Hi, hello.
Yes, thank you, ma'am.
So I just wanted to be asked to be clear on all this so that also back in the clinics we can inform our medical officers and interns and everyone. So you've seen a diabetic and during your routine consultation, you've examined the feet, you've used your tuning fork and everything, check sensation, and you find out that there are decreased levels of sensation or the perception is not optimal, or she can't feel vibration. So at that point, there's no ulceration, everything else seems fine, but she's already having signs of having a diabetic foot. So at that point, are you sending the patient to the physician? Are you sending to the podiatrist for foot advice? What do you do? Who do you send? Or you just advise the patient and continue optimize your treatment? What do you do then?
Thank you for that. I think Dr. Sigo is also listening, but yes, Doc, you can close on this one. Thank you.
Yeah, so at this point, this is when the patient is diagnosed early that they're developing complications of diabetes. So at this point, this is where you continue, you continue to optimize your glucose control, and then now you have to start food protective treatment, meaning now we know that the patient has some kind of neuropathy, meaning they are prone to trauma, they have lost sensation. Now we have to emphasize for the patients to look at their feet every day. Like there's somewhere where I've read where they say the patients must take care of their feet the same way that they take care of their face. Meaning when you wipe your face, you check every corner that you've wiped properly there, you put lotion properly and everything. So they must do the same thing to their feet. Make sure that the spaces between the toe, it's nice and dry, and the foot is well lotioned. They must look at their feet. They must avoid wearing shoes that can be tight. So it's education, because they can't feel that the shoe is tight. So they must wear soft shoes, sneakers which are soft. Avoid the leather shoes or the hard plasticky shoes. They must avoid that and wear soft shoes, so that even if it's tight, it does not cause a lot of pressure. And then at that point, you can refer the patient to the podiatrist so that they can continue to monitor the patient and assist them when they develop calluses and other stuff. And if the patient has an X-ray and you can see that there's a bony deformity, that's when the patient needs to go to the orthopedic surgeon, because that's when they can do some corrective surgeries to correct the bony deformities, whether they have to put on screws or some K-wires to fix the deformity. And if the or if you cannot find an orthopedic surgeon or a podiatrist, the patient can still be referred to a surgeon. And then there we will continue to monitor the patient and refer the patient to the correct place. Because if the patient is there in the referral hospital, there is access to prosthetic shoes and all of that that can be custom made for this patient, so that their foot is protected and we prevent the progression of the disease that has already occurred.
Thank you very much. As we close, colleagues, we have come to the end of today's session. Mr. Dr. Sigo, are you there? Can you just do the vote of thanks to our colleague, and maybe your closing remarks on the issue of diabetes and the legs, and thanks, Doc.
Yeah, I think we are really blessed and excited to have a platform like this, and for us to have our colleagues who have studied more than what we have studied and come to share with us. We really appreciate it very much, Dr. Machete. The other issue, maybe my closing remarks is, I think it's about time as maybe doctors, especially in terms of either SAMAS, South African Medical Association, or whatever structure that we have, to really look seriously into the staff establishment within the primary health care district and so, because the very same issue that we are talking about of multidisciplinary approach. It becomes a problem when you don't have enough posts, maybe for the dietitian. I mean, in my own sub-district, I've got one full-time dietitian and a concept for a quite number of patients, and that cannot be right, you know, under any other circumstances. The physios that we need, you know, the hospital become overwhelmed with so many people being referred to a central place. And we are raising the issue of finance for our patients to actually access those places. So we need to have resources, you know, maybe down referred back to the primary health care, where we can help people before they, you know, get all these sorts of complications. So I think the element of advocacy for making sure that we've got enough staff, different cadres to look after these people becomes very important for me. But on that note, Prales, thank you very much, and we hope we will engage more to really improve, you know, the healthcare of our people, you know.
Yes, thank you. Thank you very much, Dr. Zico. Dr. Machete, closing remarks. We are done. Thank you.
All right. Yeah, no, all I want to say is that thank you for everyone who logged in to participate and listen in on this surgical seminar. I'm looking forward to more. I'm very excited that we're all going to be reading more and discussing more surgical topics and yeah, improving the clinical care of our patients. So yeah, thank you for everyone for participating in this. Thank you, Dr. Mawela.
Thank you. Thank